and welcome. No, no. This is Dr. Deuk Majan. We are here at the Deuk Spine Institute and Surgery Center of Viera. Our patient is here with several problems, and she is a patient who, AP, who we've known for a long time. She has had surgery here before, and she's had the Deuk procedures, the Deuk laser disc repairs. She presents now lateral with a herniated disc at T11-T12. So basically she's had spine issues for a long time. She had neck herniations, back herniations. Now she comes to us with a thoracic herniation, T11-T12. And this herniated disc is pushing on her spinal cord. And so her options were laminectomy or this procedure. And she did not want a laminectomy. Frankly, I don't blame her. I wouldn't either. So she opted for the Deuk laser disc repair, which is endoscopic. Shot? Let's get an AP and see where we are. So you can see that. Kind of a wedge deformity. 5, 4, 3, 2, 1, 12. It almost looks like 12 is the wedge deformity. Yep. Very good. So that makes sense. 12 being the wedge deformity. She doesn't have much pain in this area. We're not doing the surgery for pain. We're doing the surgery because what she has is she's getting numbness and tingling from spinal cord compression. Shot? So I need to get into that disc. I'm hitting the facets, shot, but other than that, it looks good. AP, you can see I'm touching the facet joint with the tip of the needle. We're starting on the left side. AP, quick, just a quick shot. Nice. All right, very good. So I'm happy with my position on the lateral. I need to be a little bit more lateral on the AP view so I can get around the facet. It's always good to start a little bit more conservative. Shot. Yep, there it is. So we're getting around the facet. Shot. Shot. AP. So right now we're at the back of the disc. We're coming in through the foramen, called transforaminal. That's the approach. You can see the herniation. Yep. Perfect. That is absolutely perfect. Now let's just go back to AP. Go back to AP. And let's confirm that we are at T11-T12. Now if you look at the ribs, we're at T11-T12 because the 12th vertebrae has a rib and that's the bottom. Let's go down south a little bit and we'll count up. That's good, that's good, that's good. All right, there's sacrum. 5. Yeah, go to the pedicle though. Use the pedicles. Always count by pedicles. Sacrum, 5, 4, 3, 2, 1, 12. Perfect. And then 11 would be above. So we're at 11, 12 when you count from sacrum up, and we're at 11, 12 when you look at ribs. And if you look at the MRI, T12 has a wedge deformity, loss of height 10%, 15%. So the reason I'm taking so much time to make sure we're at the right level is that that's the biggest problem with thoracic surgery, is you get the wrong level. All right, here we are. I'm going to enter the disc at this point. Shot. Just want to make sure it's looking good. Yes, yes, yes. Shot. Perfect. Yep. Very good. Now we're going to go to the other side and do the same thing. So she has a herniated disc at T11-T12. It's literally pushing on her spinal cord, causing damage to her spinal cord. And she's getting symptoms with her bladder. Now, of course, people get symptoms, ladies in particular, get bladder symptoms as they get older, as their pelvic floor weakens. And you can't always ascribe bladder problems, urinary problems to, the spine or spinal cord. You have to rule out other causes. And the most common is, pelvic insufficiency, where the muscles in that pelvic floor get weak. And I'm not, but she definitely has a pinch on her spinal cord, so we need to fix that as well. That's why we're here. We're not here for pain on her thoracic, we're here for pain in her piriformis. She also has sacroiliac joint pain, but we're not treating that today. All right, and here we go. AP, perfect. So I got lucky. Looking good, looking good. You can see the other needle is in the middle of the disc, which is what you want. That's the perfect placement. And again, both of them are at T11-T12. So here we go. I will say this. I was not born a needle jockey. I had to become a needle jockey. All right, what's a needle jockey? Needle jockey is a surgeon who manipulates needles into the patient. And most of the time, needle jockeys are pain management doctors. Shot? Well, all right, hold on. Shot. All right, you can see we're inside the disc. Shot. I got rid of the Ratex, so the squiggly lines are gone. But yeah, you can see we're inside the disc at T11-T12. Let's get an AP to verify. And then we'll start our laser disc repair with a small scope. What? Well, let me see. Yeah, perfect. Well, maybe we'll start. We'll just see. Let's see. She's pretty relaxed. How's she doing, doctor? Good? All right. Just have it in the room.
Yes, sir.
All right. We're going to make a skin incision, and I'm going to place my dilator. This is going to be a 7 millimeter. Don't open anything yet, okay? Here. Let's see if we can make this work. Shot. I think you need to bring your collimator down, and there we go. Don't open it. Shot. Yeah, it'd be better if we can get the larger scope in. Shot. I'm looking for my guide wire. Shot. You see it there, Jordan? Not yet. Do you see the guide wire? Nope. All right. I think it's there, but the needle is over it. So I'm going to take my needle out. Shot. Guide wire is there. You can see it now quite clearly. Any questions?
At this moment, no current questions.
All right. So here we go with our dilator. Shot. I can use some numbing medicine in this area because we're not too close to the spinal cord. But when you get too close to the spinal cord, you don't want to use numbing medicines. Otherwise, you'll get spinal anesthesia. Right? And I don't want to do anesthesia. That's Dr. Burndes' job. Everything okay?
Yeah.
You okay if we bring the next lady back?
Can we wait a couple minutes because I want to take her to recovery?
Oh, okay, yeah, sure. Yeah. I mean, just tell us when you think it's okay. We're not going to bring her back right now. I was thinking, when we start the piriformises. You think that's too soon? Just let me know when. Hold on. Let me just see. Shot. All right, so I'm checking my alignment. It looks good. I think we can go ahead, yeah. She's got a big herniation, and it's one that I really want to make sure we can get aggressively remove. So I need the bigger scope for that. Smaller scope, I won't be able to be as aggressive. That's it. Shot. Once again, we are transforaminal. We're approaching the herniation from the side.
Suckers on.
Suction on.
All right, please. Thank you.
Grab her. Damn. Yeah. We need to bring it back just a little bit. Let's get, we may have to use the cervical. Let's see. Let me see. Laser. There's some herniation right there. That white stuff. Where's my pedal? All right. That's herniation. Apologize, the visibility is not great. This is all disc herniation right here. And it's very hard, calcified. This is what's pushing onto her spinal cord, causing the problems. My job is to try to remove as much as I can to remove the pressure off of her spinal cord. Now, I told her this may not fix her problem. And I didn't expect it to, with her bladder issues. Well, hopefully it helps, but it still needs to be done. It's got some osteophytes. A little bit of diploic bone. What?
Did you know that we have the short lumbar?
The short lumbar?
Can we use that?
Take that. We can. It's not the issue, though.
No, I know, but not in this case. I'm saying like a...
God, why is the view is either too zoomed in or something?
You know what I said for the other case? Do you think it should be tried?
I don't think the length of the scope's the problem. Okay? I think it's the width, if anything. You know, she probably needs something in between short and long.
Yeah.
And I just need this laser to get to the area I need it to get to. This is the herniation right here, guys. It's, I can't get to 12 o'clock. You know, it's the other direction, that's why. Pull towards you.
Towards me?
Yeah.
Better?
That's better. Yeah. By the way, when you remove herniations like this, you're never going to be able to get the whole herniation. Our goal is to get as much as we can, safely. I get people asking me all the time, Is the MRI going to show the herniation is gone? No, it's not. The MRI will not show the herniation. Everything okay?
Yep.
The MRI will not show the herniation is completely gone. The MRI is going to show that it's been debulked. It's very, very thick, full of scar tissue. And calcium. As discs degenerate over time with herniations, they get worse and worse, they get more collapsed. You get bone spurs and bone spur formation. Bone spur is basically bone. And the good news is the laser is quite good at removing bone and bone spurs. What's wrong?
Just getting the mask adjusted.
The mask? All right. Laser off. Grabber. Do you see the marker for the laser there? Or is it the other way around? Hold the tube.
Yes, sir.
You guys doing okay?
Just readjusting the CPAP. It's a little
Hold it.
big. Yeah, it just seems a little big.
Hmm? What is this? I don't need distractions here. Can you put the light on here?
Can we turn on light too, please?
Yeah.
As well, please?
I think, can you tell where the
I think
mark
it's
is?
maybe it's probably on the other side. Yeah. I think the number's here. Yeah.
That's why. It looks the opposite way. No,
Oh,
yeah,
Yeah, right now.
a lot of bone spur bleeding.
Wow, thank you. Yeah, thank you.
All right. Let's see here. Okay. Again, this is the herniation, very thick. This is very, very dense. This is what's been pushing onto her spinal cord right here. And we're just trying to remove as much of it as we can safely. After this, we're going to move on to the piriformis muscles. She has horrible pain in her buttocks from torn muscles in her buttocks. And it's called piriformis syndrome. Very common problem. And fortunately, there's a way to fix it now, where we go in and release the tension in the muscle. Grab her. Hold. No, it's fuzzy because of some blood. So the more bleeding there is, the more, these are all pieces of herniation. The more bleeding there is, the more fuzzy the view is. And she's bleeding because she has some bone spurs here that are bleeding. Basically, you could see little pieces of diploic bone, and could be from her fracture. That's right. That's likely what it is. It's the fracture and the osteophytes. There's another piece of herniation, and it's really hard herniation. In other words, it's like really thick, callousy. It's like a we call it a callus. It's a callus. You know. Callus is just scar tissue, right? Isn't that right, Davis? Yeah, callus is scar tissue, and that's what she has. So, but instead of this callus being where there's a fractured bone, well, there is a fractured bone, but this is a callus in the disc, basically. You can see all the pieces of herniation right there. Now, I've said this before and I'll say it again. We are not going to get 100% of the herniation, so don't expect it. Our best is going to be 70%. Usually we're going to get 50. But the key is to get the right 50%. Any questions?
At this moment, no current questions.
Yeah. Okay. Well, that's pretty much it. I can get a little bit more here. But it's calcified. It's pretty calcified herniation. Not entirely calcified, but this part of it has a lot of calcium. Making it rock hard. Grabber. It's really hard to get rid of it. And that's really what makes it so it's so hard to visualize for you guys, is the bleeding. Not a lot, very little, but when you're looking through an endoscope, any amount of bleeding, you know, is significant because it obscures your view. These are all little pieces of herniation there. Each one a few millimeters. Individually, they don't make up very much, but collectively they do. I'm just trying to get as much of this herniation as I can. Again, it's very hard. I think that's all I can get on this side. I'm just stirring up bleeding every time I go in. That's the epidural. There's the end right there of the disc. I can just get this last bit and that's really it. All right, there's the fat in the epidural space.
2 on, please. Thank you.
Irrigation. This is clogged, I think, maybe. Come on, Luis. Come on. Huh? We've done one side. I'm thinking about the cervical scope for the other.
Can you open that, please? Somebody?
Because I think with the fracture being there, a cervical scope is better. Watch out. She doing all right? Shot. 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 So that's just dye that's leaking out the front of her disc there. We'll make a small incision with the smaller scope. We don't need the big incision, 7mm. We can usually get away with a 4mm incision. Shot. All right, now we have a smaller dilator. So normally I would prefer to do this level 11-12 with a larger scope. However, I just can't do it because she does have the fracture. I think she has some osteoporosis and it's just not working well for her. So I'm going to go with the smaller scope. Shot. All right. Now let's get an AP. Shot. Looks good. We're right there at the back of the disc.
Don't open it. Nope, thank you.
All right, I'm going to need the mallet. Nice. Shot. Again, because she has a fracture at the end plate there, you can see it. That's right where we're working. And having a bigger scope, it's kind of being forced down into the top of the fracture, which we saw last time, and we don't want to do that again. We're going to try to avoid it if we can. The smaller tube and scope should help me steer a little bit better clear of her old fracture. Shot.
Disconnect the other one.
Very good. We're in.
It's okay, leave the other one too.
We are in. I got this. You just work on that. Got to take my dilator out. Coker. It's gotten wedged in there. Let me have that. Let me have that. Just work on the other stuff. I don't know if this is going to work. It's a little too flimsy. Yeah. All right, we're going to try to pull this out with our coker. There we go. Okay, we've got our tube, so we have our access, and what should be okay. I got the pedal. We're good. We're going to do this right side, and then we're going to do her, I got it. And then we're going to do her piriformis muscles. So we're going to be done in probably, hopefully about 10 minutes here. Okay? And then we'll end this stream and we'll go on to the piriformis. All right. Let's try to focus a little bit better here. And there we go. So once again, we're inside the T11-T12 disc, right inside the herniation. Now the visibility is not as good with the scope. It's the compromise for the smaller diameter, but you can see clearly we're in the same disc we were before. The other one was a little more bloody because we were, interacting with the old fracture, and there was some bone spurs associated. But right now I'm doing a debulking of the herniation. My goal here, let's turn the light down a little bit. Our intensity is too high. It's just too bright. There we go. See, thank you. We see the same thing we saw on the other side. A lot of hard herniation, really starting to calcify, okay? And every herniation, if you give it enough time, it will start to form calcium inside the herniation. And that's only going to make the herniation even harder, like more rock hard. And remember, these herniations are right next to your nerves. Nerves are soft. If you want to know what a nerve is like, think about soft tofu. How many of you had soft tofu in your lifetime? If you've never had soft tofu and you want to know what is a nerve really like, go to the store and buy a container of soft tofu and literally open the lid and pinch it with your finger. What's so funny? Yeah, that's and I'm not talking hard tofu, I'm talking soft tofu. Okay, pinch it with your finger and you will know exactly what a nerve is like. And this stuff here, this herniation, this is hard. It's like, look at that piece of herniation right there. It's literally like, it's not, everyone says crab meat because it looks like crab meat, but it doesn't feel like crab meat. It really is more like, I say shrimp, but this old calcified herniation is not like shrimp. It's more like, what's the word I'm trying to think? Do you guys know what a mimolette is? Davis, you know what mimolette is? It's a type of cheese. It's a very firm, hard cheese. Not that I'm hungry, but that's this. Well, that's what, pathologists of old used food references to describe pathology, right? Port wine stain, caseating necrosis, you name it. The pathologists love to use food terms to describe pathology. So I'm just trying to stay in that vein. So it's kind of like wax, hard wax, I guess. Like not soft wax, like candle wax. I think candle wax is fair. It's fair to describe these thick collagenized herniations as being a lot like candle wax. Hard candle wax. All right, so I'm inside the herniation right now, and I'm literally using the laser to break it up into pieces. I'm trying to chop off as much as I can. I won't get it all. And tell everybody I'm not going to get all your herniation, because I can't. It's not possible. Nobody can, by the way. See, this is better, Luis. For this particular patient, at this particular disc, it's just a better thing. So I think it's always good to try to get the larger scope if we can, but you got to look at the disc and you got to say, how much of this can we really get? You know what I mean? Is this disc collapsed? If the disc is too collapsed, we got to go with the smaller scope. In her case, her disc here is pretty collapsed. So I think it was a good try. But we gotta, in her case, the smaller one is better. So that piece of blue is nucleus pulposus, degenerated, not normal, degenerated. Normal nucleus is white. It's not blue. And that was blue. And that was a tiny little piece, right? What is all this stuff I'm removing? This is all scar tissue. This is scarred nucleus, scarred herniation. There's a piece of herniation. You see it went up and out the tube, right? That is exactly what causes the inflammation, that herniation. It irritates the body, and this annulus, there's a piece. It irritates it so badly that it causes inflammation. Well, guess what inflammation does? It makes scar tissue. And then calcium. So all of this stuff is a result of the herniation. And unfortunately, over time, the response, we're almost done, 5 minutes, doctor. Unfortunately, the response of the human body to a herniated disc is to attack it and to make scar tissue and calcium. And that's what's happened here. So I think she probably fractured her spine at the same time she herniated the disc. And the fracture healed for the most part, but the herniation never did. And it ended up causing, you know, pain. And now so much scar tissue, callus, that it's pinching the spinal cord.
We have a couple questions.
Sure.
This first one comes from Fiona on YouTube.
Hi, Fiona.
They ask, "Hi Doc, just curious why thoracic is more difficult and surgeons don't like working there, etc. Not this patient, but just in general."
Yes, you're correct, because thoracic is very high risk. The spinal cord is there. Some very difficult structures to navigate around are there. Blood vessels, nerves, the lungs, the lymphatic system. I mean, it's truly no man's land, no woman's land, whatever you want to call it. Surgeons stay away from it. But the truth is, I stayed away from it for many years. But I had a patient who told me he was in so much pain that he was going to end his life if I didn't do it. And I said, well, at least with me, there's a chance he'll survive, you know, the surgery. So I did my first thoracic transforaminal DLDR 4 or 5 years ago now, right, Luis? And the guy didn't just survive, but we got rid of his pain. And he was the happiest person. And he was very thankful and appreciative that we did it. And I thought, you know, it really wasn't that bad. So I started doing some more. And here we are. And we don't turn anybody away. We can do it. Yeah. It's just a very, very delicate area. And most doctors are afraid to come here and work. I mean, I'm afraid to come here and work. I don't look forward to doing these cases. But I do them because nobody else will do them. I do them because my patients need me to do them. And they're not going to get anybody else to do it. I mean, if there was someone else doing it, sure, I'd be happy. Let them do it. I got enough business with lumbar and cervical. But the reality is you're right. Other doctors won't do it. So the patients suffer. And I don't want people to suffer for something I can fix. But yeah, it's a dangerous area because of all the spinal cord and the nerves and the lung and the lymphatic system and the blood vessels. And it's really hard to get to. But we're actually going through a small hole in the side of the spine to get to the disc. It's called transforaminal. And I guess I just could say that I feel comfortable enough to do it. All right, so you can see already we've debulked quite a bit of this herniation. And we're almost done as much as I can do. Remember, I can't get it all. And I tell people that. I can't get it all. So don't be disappointed if I didn't get it all. But let's see. Maybe we can get enough of it to make you feel a lot better. And that's really what we're trying to do.
We have another question.
Sure.
This next one comes from JMC on YouTube.
Uh-huh.
JMC asked, what is the best nerve pain medication?
I don't know, JMC, what the best nerve pain medication is. I don't think you should treat nerve pain with medication. I think people should get their nerve pain fixed. And we can fix it usually. The only kind of pain that you should ever be taking medicine for is a type of pain that there is no cure. And there's one type of pain, there's two types of pain that do that. Complex regional pain syndrome and then of course,
Cancer pain.
well, yeah, cancer pain, neuropathic pain. But if you have a pinched nerve pain or you have a disc injury pain, come here and let us fix it. Don't take meds. You don't want pills. Pills aren't the right answer. They're going to mess with your brain. They have side effects. People get addicted. People get dependent. And basically, medicines don't fix anything. This does. So come get this treatment and you won't need pills. Unless, of course, you have complex regional pain syndrome, which there is still a treatment. It's sympathectomy, and we do those. So you might even be able to get out of pain for that as well. All right, this should be the end of the herniation right here. I'm almost outside the disc. We're just right there. We've been inside the herniation the whole time and removing it piece by piece. It's called piecemeal. I think this is the outside, just about the outside of the disc right there. Or I should say herniation. Any other questions?
At this moment, no current questions, but we do have a comment from Fiona saying, thank you for taking that chance.
Yeah, you're welcome, Fiona. You know, sort of an act of desperation with my patient, you know. And it takes you outside your comfort zone as a surgeon. Surgeons really don't like being outside their comfort zone, just like people don't, you know. And when you do something new in medicine that nobody's done before, you take a huge chance. Obviously, if you have complications, you're going to be crucified. But how can you make progress in medicine? How? If you don't try something new, something different. That's, you know, reasonable, of course. Not just brazenly crazy, but you know, you calculated risk. You have to take chance and you have to do new things. If we don't, I don't think we're doing the best for our patients. We have to be willing to try new things that have a good chance of working. And we've been doing this now 17 years. We know it works. So I feel very confident in the technique at this point. But you're right. Back in the day when I first started doing it, it was scary. And I'm thankful that I did it. And my patients are thankful I did it. But at the same time, it wasn't easy to do. I could have just kept doing fusions, laminectomies, ACDF, thoracic laminectomy, thoracic fusions. I could have just kept doing those invasive surgeries that, you know, they pay very well, but they're not good for the patients in the long run. And I wanted to do better. I wanted to be better. And I was lucky in a way that I came across this technology and was able to advance it myself, make it better. And that's what it's all about. Now that I've done it, I feel a lot more confident, you know, making other advances. So, yeah, I thought I'm almost done, but It's like the never-ending herniation here. I need at least probably another 2 minutes, so I want to get as much of this as I can for her. You know, patients trust you as a doctor. You really need to do what's best for the patient. You need to try to do your best for them. I'm trying to do my best for her. She's, as I said, she's been here before. She had her back fixed, she had her neck fixed, and now she has her thoracic she's getting fixed. And we never treated her piriformis definitively, and now we're doing her piriformis too. I think this is going to go a long way to help. This is a pretty good decompression here. I'm pretty happy with this. Just about done. We've created a nice void for what's left of the herniation to have some more room, so it doesn't want to crush the spinal cord anymore. So I'm pretty happy with this. So our next patient, for next surgery, we're going to do a piriformis. You're going to see that. But then after that, I'm going to go do a cervical DPR for a lady who has facet pain. And then we've got one more surgery and we're done. That's the end of the disc right there. Just to give you a perspective on the size of this annular tear, the laser fiber is 1/2 millimeter wide, 0.5. All right, that's the outer fibers of the annulus right there. So we are now, right there is the last of the disc. And the laser has done a great job as always. It's my favorite tool in medicine now besides the scope. That's it. All right. Thanks. Great job. Let's go ahead and end the stream, and we're going to come back in a minute with the piriformis release.